Good evening, everyone. We are over here to discuss the INICET recall questions with the which have come from the subject of pediatrics. I am Dr. Deepali Gupta. So these questions are basically based on the recall. Some might be erroneous. Please excuse me for that. Whatever recall we have got, we are going to discuss on the basis of that, right? Okay, so the first question which came to me was, according to NADA's criteria, which of the following was a minor criteria? And this had multiple choices in the form of A, B, ABC, or A and C, like that. So what options did I get was whether it is soft S2, low blood pressure, diastolic murmur, systolic murmur of grade 3. So if we see what is the NADA's criteria are used for the diagnosis of congenital heart defects. And if we go back to our learning, we know that there are major criteria and minor criteria. There are 4 major criteria and 5 minor criteria. Presence of any one major or presence of 2 minor indicates the existence of congenital heart defects. And they are usually to be used in children less than 5 years of age, because after 5 years of age, the acquired heart disease also creep in, and namely your rheumatic fever and rheumatic heart disease. So therefore, they are more applicable or more consistent when they are used. The NADA's criteria are used for the diagnosis of congenital heart defects in children less than 5 years of age. So let us look at what are the major and what are the minor criteria. So in the major criteria, we have systolic murmur grade 3 or more in intensity. We have any grade of diastolic murmur and the presence of CCF or the presence of cyanosis. These are the 4 major criteria I was talking to you about. And then in the minor criteria, we have systolic murmur less than grade 3 in intensity. So if grade 3 is written, it comes in the major criteria. Less than grade 3 comes in minor criteria. Diastolic murmur of any grade has already come in major criteria. So in the minor criteria, we have the abnormal second heart sound. In fact, this is such a typical diagnostic feature of heart diseases in children. Any problem, any abnormality in second heart sound bound to have congenital heart defect. But then, since its interpretation is largely subjective, depends on the hearing acuity of the listener, of the observer, therefore it is placed in the minor criteria. Abnormal ECG, abnormal chest X-ray, and abnormal blood pressure. So all these would come in minor criteria. So if we revisit the question, let us see. Soft S2, of course, soft S2 is an abnormal second heart sound. So this is, of course, one of the minor criteria. Then so soft S2, yes, this is one of the minor criteria. Then low BP, yes, this is also the minor criteria. Diastolic murmur of any grade is definitely a major criteria. And systolic grade 3 murmur or systolic murmur of grade 3 or more is again a major criteria. So the correct option would be the options having soft S2 and low BP. So probably in our question, the correct answer would be A plus B, or both. Let me write both A, B, right? So whatever the case may be, the question might be having these same choices at different options, so that you could have answered very easily. A sort of easy question to begin with. Then let us move on to the next question, and that is history of 4-year-old boy with Kawasaki disease. What is the management? Of course, they have given the snapshots, the pictures of the cardinal features of Kawasaki disease. One is your strawberry tongue, other is the Bewes lines, which is usually seen during convalescence in Kawasaki disease, and third is the rash, the pleomorphic or the polymorphic rash seen in Kawasaki disease. So what do you give for treatment? Of course, the first and the foremost is IVIG. In recall, I was also getting something there was written about myocardial infarction also. So anyways, IVIG has to be given. That is first and the foremost. So if there was one choice only and there were no combination of choices given in the final options, then we will definitely go for IVIG. But let me tell you, aspirin is also given. Initially, it is given at a higher dose, and then for its anti-inflammatory anti-inflammatory action, and then later on it is tapered to lower doses and continued for a longer period. So let us look what is Kawasaki disease all about. So first of all, you should know that fever lasting for at least 5 days, and then presence of any four of the following conditions. So what are the following conditions? Bilateral non-purulent conjunctivitis, then changes of mucosa of the oropharynx, that is strawberry tongue, which we just saw, and injection of the pharynx, then changes of the peripheral extremities like bipedal edema or erythema of the hands or feet. And as we know, in the convalescent stage, we may see desquamation. The typical areas where we see desquamation is the perioral and the perianal desquamation, but they are seen in the convalescent phase and not in the acute stages. And of course, as I was telling you, polymorphous rash, but never a vesicular rash. That is one of the criteria. And of course, cervical lymphadenopathy, at least one node should be 1.5 centimeters, and usually it is seen unilaterally. Apart from this, illness not explained by any other disease process, and Bu's lines as seen in the convalescent phase. And the basic pathophysiology of Kawasaki disease is the necrotizing vasculitis of the medium-sized vessels. So that has to be kept in mind. And the most dreaded complication, as we know, is the giant coronary artery aneurysms, which are responsible for MI. You know, there are only two causes of myocardial infarction in children. One is Kawasaki disease because of the development of giant coronary artery aneurysms, and second is Al-Kappa, anomalous origin of left coronary artery. So these are two causes of MI in children. Otherwise, MI, as you know, does not occur in children. So because of this dreaded complication of giant coronary artery aneurysms, we start the child on IVIG to halt the immunological attack. And of course, the inflammatory condition which have already developed, to reverse that, we have to give an anti-inflammatory drug in form of aspirin. Right. So that is what had to be done. So here we would go for IVIG as the first and the foremost therapy to be used in the treatment of Kawasaki disease. And as I was telling you, if there would have been multiple options, then A and B both would have been the correct answer, right? Okay, then next is treatment we have already done. As I was telling you, aspirin is initially given at the dose of 75 to 80 mg per kg till the child becomes afebrile. And then, of course, low dose aspirin is continued for few weeks for its antiplatelet activity. And as we already know, in Kawasaki, we get to see thrombocytosis. Now, a bit of, I would tell you something which is just out of the box. Thrombocytopenia is also seen in Kawasaki disease. However, thrombocytosis is the classic manifestation. But if thrombocytopenia is there, remember, this child has a very high risk of developing giant coronary artery aneurysm. So I had written a paper on this, thrombocytopenia in Kawasaki disease. You can check it out on PubMed. It is there. Yes, it is a finding in Kawasaki disease, but the classic learning is always thrombocytosis. So keep that in mind. So that has to be taken care of. Then let us come to the next question. What is the complication caused by organism associated with the given image? So this is a typical slab cheek appearance which was given, and we all know this. We are talking about erythema infectiosum, also known as the fifth disease, caused by none other than dreaded parvovirus B19, right? So parvovirus B19 causes this slab cheek appearance, erythema infectiosum as it is called. And of course, it is also responsible for the aplastic crisis, very commonly seen in children having chronic hemolytic anemias, something like sickle cell anemia or pyruvate kinase deficiency or hereditary spherocytosis. So in these conditions, parvovirus B19 is supposed to cause sudden drop in hemoglobin along with reticulocytopenia, because this is aplastic crisis, and there is total halt in the manufacture of RBCs. And these children would come up with additional symptoms of, because there is lower hemoglobin, the hemoglobin has dropped drastically, so they may develop severe anemia, pallor, fatigue, and palpitations because of the decrease in hemoglobin. So this is nothing but the answer was pure red cell aplasia over here because of the aplastic crisis caused by parvovirus B19, which also gives rise to a slap cheek appearance. So this is the typical erythema infectiosum that has been discussed over here, usually seen in the age group of 5 to 15 years of age, and it is usually the prodromal symptoms are of low-grade viral infection, and the typical appearance of erythematous flushing of the face is referred to as slap cheek appearance, and the rash then starting from the face spreads rapidly to the trunk and proximal extremities as a diffuse erythematous macular rash that rapidly undergoes a central clearing. This is the hallmark of the rash of erythema infectiosum. You have to remember it, that it goes central clear, it undergoes central clearing to give it a lacy or a reticulated pattern. The rash gradually fades over the coming 1 to 3 week period, and this is typically known as the fifth disease caused by parvovirus B19, right? Then there was a very interesting question, really like this question, and that was a DPT has been given to child. Since they have written DPT, so most probably they are referring to whole cell DPT. So whole cell DPT, or DPT as we call it, is given to a child at 6 weeks, following which the child develops inconsolable crying. At 10 weeks, what would be the next step? Right, so do we give DPT again? Do we give DT? That means omit the pertussis part. We don't give DPT at all, or we skip a month and then give DPT after 1 month. So these were the options which were given to me on recall. So if we see this question, this was a very straightforward question. I'm sure many of you must have got it right. So please remember persistent crying or inconsolable crying for 3 hours, or maybe hypotensive, hyporesponsive episodes, right? And high-grade fever of more than 40.5 degrees centigrade. These are not contraindications for DPT vaccination. And it is usually seen that if these episodes are seen with the first DPT vaccination, and if you give DPT again, usually these episodes would not occur. So therefore, in this, the correct answer would be we have to give DPT to this child, right? So there is no option of not giving DPT. You will continue with whole cell DPT. It is not a contraindication. So obviously the next question which arises, ma'am, what are the contraindications? So there are two main contraindications. One is if the child has history of anaphylaxis, then definitely next time DPT is not to be given. This has to be kept in mind. And this actually applies with every vaccine. If the vaccine has to be given in multiple dosages and with the first dose, the anaphylactic reaction has occurred, you are not supposed to repeat the vaccine, right? So there would be some adjuvant or some component of the vaccine which is causing anaphylaxis in this child, and obviously this child would have the repeat episode if you give it again. So that is one contraindication you have to keep in mind. No DPT. That means you can't even give DT in this case. So that has to be, kept in mind. Then the second contraindication given over here is the development of encephalopathy in the coming 7 days following the previous DPT vaccination. So in this case, what are we supposed to do is the next time we omit the pertussis component and we will give DT. So that is what is, as you prescribed or as detailed by Indian Academy of Pediatrics in their guidelines. It is this what we have to follow, that in case of with a history of encephalopathy following vaccination, any pertussis vaccine is contraindicated and only DT can be given. So that is how you are going to approach this question. And of course, as I was telling you, events such as persistent inconsolable crying for 3 hours duration, or hyperpyrexia of more than 40.5 degrees centigrade, or HHE, this hypotensive, hyporesponsive episodes occurring within 48 hours of DPT vaccination. And of course, the fourth one also, that if seizures occur with or without fever within 72 hours of vaccination, they are just considered as precautions for further administration of DPT, and they are not considered contraindication. This should be very clear. Of course, there is one relative contraindication, and that is progressive or evolving neurological illness. So that is a relative contraindication to the even the first dose of DPT vaccination. However, DPT can be safely given in children with stable neurological disorders. Again, for them, this is not even a relative contraindication, not even an absolute contraindication. For stable neurological disorder, it can be given, and for evolving a neurological disorder, of course, it's a relative contraindication as far as the first dose of DPT is concerned. So we have to weigh the risk and benefit and then take a decision accordingly. So I hope this was a very nice question and most of you would have got it right. Then again, a very sketchy question that came my way was child with 3 days of vomiting, watery diarrhea, presented with altered sensorium. Possible diagnosis include. So what I was told was these were multiple choice question. That means the final answer was something like A, B, or A, B, and C, or A and C, whatever the combination would have been. So what do we consider in this case? So most likely here, if you see, since the child had watery diarrhea and not bloody diarrhea, and the duration is also very short, so HUS is definitely not the option over here to be considered. So here, severe dehydration, yes, you know that following vomiting and loose stools, the child can go into severe dehydration, and that is one of the cause for altered sensorium. Hyponatremia is very, very well recorded to be the cause of altered sensorium in children presenting to you with acute gastroenteritis. And of course, cerebral venous thrombosis, this usually follows a bout of dehydration, especially in children who have some underlying disorders which have a prothrombotic state existing along with it. So it's something like nephrotic syndrome. So tomorrow, if a child with nephrotic syndrome and has a bout of acute gastroenteritis, this is one complication that we are supposed to consider. For that matter, even iron deficiency anemia. Why iron deficiency anemia? Because iron deficiency anemia usually also has increased number of platelets. So thrombocytosis is there. You look up any blood picture of severe iron deficiency anemia, the thrombocytes, that means the platelets, are in increased number. That's a prothrombotic state. So even that is known to cause cerebral venous thrombosis, especially if complicated by a bout of acute gastroenteritis. So for me, all these three options stand corrected. So probably the option where all the three barring HUS would have been the answer, right? Of course, I stand corrected if there was any other options or any other form of question was framed, then all my apologies to you. Then let us move on to the next question. The delivery procedure to be done in a baby delivered through meconium stained liquor. So lots of evolutions have taken place in the management of meconium stained liquor baby, right from the starting of NRP, revisions, we have been witnessing that usually when I was doing my post-graduation, we used to do this, that before delivery of anterior shoulder, we used to suction the mouth and the nose, right. That means the rest of the body is still in the vaginal cavity, and we used to go there. The obstetrician used to halt the process of extracting out the baby, and we used to do the delivery. We used to do the suction of mouth and nose. But nowadays, in fact, for the past so many years, I think the last revision, that is in 2015, now the latest has come in 2021 NRP, but before this, in 2015 itself, or maybe before that, it was made amply clear that the suction intrapartum, this was known as intrapartum suctioning. So intrapartum suctioning does not confer much benefit in the survival of the child or in preventing the morbidity of the child. So you better don't do it. So we had stopped doing intrapartum suctioning, right? So this is definitely not to be done. Again, this was, let me tell you, M means this was again a multiple choice answer. Multiple choice means the final answer was in the form of A, B, or maybe ABC, or maybe AD, different combinations, right? So let us see, at least this is not the correct option. Then Positive pressure ventilation in non-vigorous child after the initial steps. Of course, this is correct. Many of you would say, ma'am, we have been told that positive pressure ventilation is contraindicated in meconium stained liquor babies. No, it is not. Nowadays, for that matter, in 2015 itself, they had given in the NRP revision, that neonatal resuscitation protocol revision, that positive pressure ventilation can be done in a non-vigorous baby, of course, after doing the suctioning. Then gentle suctioning of a vigorous baby, of course, this is also correct. This is what you are going to do normally. And then tracheal suctioning followed by mouth suctioning, even this is not to be done nowadays. So this is again not a very preferred procedure. So therefore, even this is out. Initially, we used to do this tracheal suctioning, the usual steps initially. Initially means in the past, what we used to do was, since bag and mask was contraindicated, positive pressure ventilation through bag and mask was contraindicated. So we used to intubate the baby and do the tracheal suctioning, and then, do the bag and tube ventilation. But nowadays, tracheal suctioning is also not required. So definitely the correct would be the B and C option. So if any answer was there where the B and C option was there, was the combination, then definitely that option is right in this question. I hope I have made myself clear. Then coming to the next, this was a very easy question that matched the following. We know this Edward syndrome, E stands for Edward and E stands for trisomy 18. So we will match it like this. Then Patau syndrome, Patau is, how do you remember? T is for 13 over here. So you have to remember Patau is trisomy 13. Huntington's, we all know, is trinucleotide repeat disorder. And of course, in sickle cell anemia, there at beta 6 position, there is, the interchange of glutamic acid with valine, right? Of the beta globin chain. So we know this, that what renders the RBC sickle shaped, right? So this is the abnormal formation of the hemoglobin. So therefore, this was a very, very easy question, and I hope everybody would have got this correct. So the pediatric question, what I feel was sort of moderate to easy. That is it, right? Okay, then next is causes of high output cardiac failure. I don't know, I can also discuss this. We already know this is high output, this is high output, and this is also high output. So definitely the answer becomes cor pulmonale, right? So this is right ventricular failure, although this must have been nicely discussed in the medicine portion also. Okay, then iron profile and iron deficiency anemia are all. So which were the iron, what was there in the iron profile, since we see lots of iron deficiency anemia and we get the iron studies done. So definitely this would have been discussed by the other faculty also, but still I have taken it. Let us see. So there were multiple choices in this. And if you see, everything is correct because iron deficiency anemia entails low body iron. So definitely the storage form of iron is ferritin. So decreased ferritin is there. Serum iron again would be reflective of the total body iron. If that is going to be decreased. Transferrin, is a transport protein for iron. So definitely if the total body iron is less, so it will be less bound to the iron and therefore it will be less saturated. That is the reason. And increased TIBC, this is kind of hungry TIBC, for iron. So therefore the TIBC is going to be increased. We know this already. So all the options were correct, and any option in which A, B, C, and D was there would be the correct this thing, right? Okay, then maximum incubation period, we know this also for chicken pox, if you remember, is 10 to 21 days. For hepatitis A, we again know that this would be around 50 days, the maximum incubation period. Syphilis, it is 90 days. And for SARS would be 10 days, right? So I've again written over here for you. So SARS would be 2 to 14 days. Chickenpox is 10 to 21 days. Hepatitis A is 10 to 50 days. And syphilis is 10 to 90 days. So this is again, this was again a very easy question, right? So this is it about the questions which had come from the section of pediatrics. Do feel free to connect with me at the Alan Next app if there was any other question of pediatrics which we have not covered. Thank you.